Hello, everyone, and welcome to Conversations at the Lab, hosted by Globo's Innovation and Experience Lab. Today, I am joined by Katie Mechler, who is doing all kinds of really cool things at Jefferson Health. We're going to talk about a few of the surveys that she and her team have been working on to better understand what makes interpreters fulfilled and most engaged at work. And I'll turn it over to Katie. Katie, introduce yourself. Welcome to our
Hi,
conversation.
thank you. Thank you so much for inviting me. Yes, you can call me Katie. I am a family medicine trained hospice and palliative doc at Jefferson Hospital here in Philadelphia. And yeah, I'm really happy to be here.
Fabulous. Wait, is it Dr. Katie Meckler? Did I leave off your
I don't know, it doesn't matter.
Well, I'm all about like if you have the doctor, you might as well put it on
That's
there. All right, good deal. Well, Katie, the first thing that we like to talk about, so this is all about for those that are pursuing language access and equity
right.
initiatives, so things across language and culture. The first thing that we like to talk about is how you got here, because so few people even recognize that this kind of job, pursuing access,
Mhm.
equity, interpreting, is a thing. And so kind of where did you study? Where are you from? And then
Mhm.
how did you end up in the seat that you're in now doing some of these
Perfect.
cool things? Yeah, go for it.
Yeah. So, thank you. I've been in medicine now for quite some time, and so when I had a nice experience before I went to medical school. I took a gap year and I did a year with Jesuit Volunteer Corps and ended up in a family shelter in Jersey City, New Jersey, is the place that they sent me. I came from California. I didn't know anything about the East Coast, and they sent me there. And I just learned a ton. And I really went into medical school thinking I was going to do maybe like oncology or infectious disease. And I ended up finding out through that experience in the family shelter that I really wanted to do primary care family medicine. And that stayed strong throughout my medical training at Georgetown. And then I went to Albert Einstein's program at Jamaica Hospital in Queens for family medicine training. And that was just one of the best decisions I ever made. I got a great experience there, and I was committed. I went in there ready to be a clinic doc, to never set foot in a hospital again. Queens being a place that's the most diverse county in the world, and I was so fortunate to have. I worked in a very international patient population. I got to work on my own Spanish language skills there, which I had some from growing up in Phoenix and Los Angeles. Um, and then I had the benefit of having just really high quality, wonderful colleagues who reflected a lot of the community there and were often bilingual and could really help me. And it was great because I had to come up in the middle of the night. We would take somebody in from JFK Airport acutely confused from rural Morocco, and I got to practice like international medicine on US soil. I got to really work with colleagues and challenge ourselves to just really help people. And I, could pull over an Arabic speaking colleague to help me, and they could not only interpret for me, but also kind of help me with cultural factors and things like that about some of the behaviors that somebody might have been showing looked very, weird and different to me, but they were like, oh, maybe something, wasn't an illness or a pathology, and it was something partly there. So I really enjoyed that. And then how I ended up from family medicine into actually hospice and palliative care was that I guess just spending enough time in the hospital and seeing people's end of life, situations just kind of be chaotic and scared and unprepared and things like that. I ended up, instead of thinking that I was going to use my passion for like patient education and wellness and be an outpatient doctor and have long-term relationships with people, I actually ended up kind of changing. And then in my role as a hospice and palliative care doctor, I have to have intense, so really quick, deep relationships with people instead of lifelong. And instead of having, conversations about how to fit like wellness into your real world outside, it's actually how to fit, your own family and personal and everything perspective into end of life care, into something that's happening anyway. How do we make it patient and family centered? How do we make it appropriate for where they are, culturally in all the ways. So I've really found that that's where my happy place lies. And if people don't know what a palliative medicine doctor does, so palliative care is a specialty training. So it's the type of medicine that I do where we do see patients that have serious illness, and that serious illness from all comers across the board, no matter what organ system or cancer or anything like that. And so we're there to help patients with their advanced pain and symptom management. And we also help families as well. So patients and their families navigate complicated medical decisions, especially when things aren't as straightforward and it's getting a little challenging.
Mhm.
Mhm.
That is so like intense of work, and the way that you got there is really interesting. Thank you for sharing. Something
Mhm.
that you said made me think about, we recently had so there's been updates to Section
Mhm.
1557 recently, and we recently had a webinar with our friends at BCT Partners, and they said something really interesting that doesn't really have anything to do with Section 1557, but that I
Mhm.
hadn't heard before, where there's cultural competency, which people have started talking about. And now there's
Mhm.
a shift to even more, instead of cultural competency, having cultural humility, which I like that
Mhm.
language. I think that makes a lot of sense. And then even more than that, now you're starting to hear people talk about clinical competency for different cultures. So the example that they gave in the webinar was there was an immigrant culture that was, or an immigrant population that came from a different place. I don't remember exactly who it was, but
Mhm.
I can look it up and post it below. And they were presenting symptoms for COPD. Like it looked like
Mhm.
COPD if you weren't familiar with this immigrant population, but it was actually something totally different that was specific to a geographic area. And they experienced a number of deaths because they were treating COPD. All these different doctors
Oh,
in the same geographic area were treating it as though it was COPD, but it was actually something totally different. The steroid for COPD was not effective and
effective.
actually made it
Yeah.
worse. Yeah.
Mhm.
And so it took a long time before
Mhm.
that knowledge was able to like seep throughout the place where they were going for care, which is like, that's a super clinician oriented thing that you don't
Mhm.
always think about when you think about access and equity. It can be a fluffier, like warmer empathy, and I totally believe in empathy. I'm the biggest proponent for like, we just need to come from a place of like, we care, and that solves most things. And
Mhm.
that's totally true. And that's an example of where if you start from a place of, hey, I might not know what's happening here and I need some visibility and awareness into the
Mhm.
populations that I'm serving, like it can have like real health outcomes in the moment, not even just like health outcomes about not having as great of health literacy, which we
Mhm.
know that, but there's things that we can do over time to make that better. But if you're just treating the wrong thing,
Mhm.
so dangerous. So I thought that was a really great example, and especially like thinking about from a clinician's shoes, like being in palliative care medicine, that
Mhm.
would be something that would be compelling to me if, because there's a range of different emotions
Yeah.
around language access.
Yeah.
Some people love it and are like, yeah, let's do
Yeah.
it, and
Yeah. And
others,
I'm really And I am proud of our field for kind of making that shift from the cultural competency to the cultural humility.
Mhm.
That's just been within the last couple of years. And I think that was a little hard for us because we are data driven and we like to, we're conditioned at this point, maybe we don't like to, but we're conditioned to take tests and ace tests and to cram
Totally.
information in and to cram information out and to make split-second judgments based on algorithms and things like that. So that cultural competency, I think, was really attractive to some of us because I could memorize and I could be like, I see a person, who is Vietnamese. They will always be blah, 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 blah. Like that was easier for us rather than having that cultural humility shift. It takes more work sometimes, right? To really know that the person in front of you is an N of one and you have to ask each time. You can't make those, there's that fine line between assumptions versus like, predictive decision based on information over time, right?
Totally, totally, totally. Okay, cool. Okay, so we talked about how you got here.
Hmm.
Why does language access matter to you? Why did you spend your time when you could study anything,
Hmm.
studying interpreters?
Thank you. So the access to language, has always mattered to me, being that I did choose to work in Queens, and it's a little less of a of something I deal with here in Center City. Certainly, that's an international population still. I have the pleasure of working with people from around the world. But so it's always mattered to me because it matters to my patients. It helps me help them better. It helps me understand them better. That I truly, if I believe what I just said about cultural humility, that I need to assess and evaluate that person in front of me as who they are at this, point in time. And I need the language access in order to do that. And I think what I've come to be interested in studying in is because I'm thankful to have access to good language services here, and I don't have to, that's already pretty well established. I don't think anybody too much needs my, help to say it matters, but I think it also matters that there's a human being on the other end of that service. And it's funny because we definitely do get taught, talk to the patient in the room, practically ignore the interpreter that's there, right? And on some level, that's the right thing to do, right? Because I should be using you language, not they, right? I should be speaking to the patient just through that interpreter. But then there were too many instances where I noted that, like, oh, wait a minute, that is a human being over there, especially as I got more and deeper into the field of palliative care. And, it wasn't just wellness visits or prenatal visits that I was asking, a third person to help me with. It was, talking about death and dying, talking about, challenges and preferences to that. And, that person did have emotions. And I think the time that it really like jumped out at me is that we're I'm so thankful to have a Chinese health information center, some employees of Jefferson that do our in-person Cantonese and Mandarin interpretation. And there was just 1 week where I was on 2 weeks, I guess I'll say, on our oncology service, and 2 Fridays in a row at 4 p.m., I swear. It was a family meeting to talk about, sad news. And I had the same Chinese language interpreter both times. And, she comes around the corner, has no idea what she's walking into. And she sees my face, sees me there. And she just goes, "Mhm." And I can't blame her. So, it started to matter to me, not just that, people had access to these language services. And I spent, I was already, I'm not, I don't think I'm mid-career yet, but I was early career, let's say, because I spent so much of that time focused on me and my process and honing my skills, right? I needed to do that for a period of time. And I feel like I'm there as far as, really, thinking about the best way to make the experience the best possible for the patient and family. And then, now it finally gave me time to kind of like look to the side and be like, oh, you're here too, feeling your own feelings. And, what more can we do to support our medical interpreters with kind of that vicarious, trauma they're at risk for being parts of these conversations.
So can you frame up for me what the study was? So it's a two-part
Yeah.
study. It started with on-site interpreters inside of your own health system, and then you're looking to expand. How to tell?
So what we kind of did then with that information, because that was not, unfortunately, I'm not the only one to have had the experience of feeling like, the interpreter had feelings that are, worthy of being explored and worthy of trying to figure out how, we as medical professionals can best support that. So we surveyed our agencies that were connected to us at the time that we had kind of connections with in the Philadelphia area of in-person medical interpreters, asked them to take a survey about what their experience is, about how comfortable they feel in those situations, and asked a few other things about if their training influenced their answer to that, if their years of experience, if a few other things that the medical team might do if it influences that. And it's funny that it was a smaller study, so I can't say that this is a totally perfect conclusion, but the answer was kind of like no, that the comfort level was kind of all over the board. and that it wasn't connected to what language they interpreted or how many years they'd been or how or what their training was. So for better or worse, it wasn't directly influenced by any of those things. Again, with a small study, so maybe it is for some people, but then for some people it isn't. And I think on one level that's a little disappointing to me because again, we want data. I want to be able to say, well, this is the solution that you need, done. But again, as we're kind of thinking about that cultural humility sort of a thing, or even just in general with human beings, that it's like, oh, there's no magic one size fits all solution to just take this pill and then you're going to be automatically comfortable with these situations. So that, that was also at the end of the day, not unsurprising that every medical interpreter is also an N of one, and they're going to have bringing in their professional experiences, their personal experiences, and everything into that situation.
So when you were looking at these results, was
Mm-hmm.
there anything that was super surprising to you that you were like, oh, I
Yeah.
wouldn't have thought?
I think the surprising thing to me, because we asked for people to, click, kind of like a scale sort of a thing. So that was a little bit more objective. And then we tried to ask for some open-ended responses to see just what people would spontaneously say to us about what made that experience easier or harder on them. And it was pretty universal that people did really enjoy having like a pre-meeting or a debriefing with the medical team, having some time to sit with them before so that they could take a breath and like know what they were going to expect, not like my friend walking around the corner, right, getting a little blindsided. And then, that kind of chance to debrief afterwards and feel like a part of the team there, that most people felt like that was really helpful, like 90 something percent, but only 25% of the people said they were routinely involved in things like that. So that was a actionable big gap. So we were
Mhm.
like, okay, well, that's something I can fix. But actually, some of the open-ended questions were actually a little dichotomous sometimes. So like to some people, they said that, having religious things be brought up in the conversation and having things like that made it easier. And on other people, that actually made it harder for them. Or knowing the patient made it easier for them just to, be part of that. Sometimes knowing the patient made it really harder for them to be a part of it. So we actually found that again, you almost can't even correlate from that then, that it truly did point back to that the person in front of you is a fully unique individual, and you can't make an assumption, so you do kind of have to ask, you do have to approach their support as yeah, with the curiosity that we've talked about.
Well, and I know the first time that we talked about this, I got super excited about could we correlate the results of the
Mhm,
interpreters that are happiest with the health outcomes of the patient? Like, could we
mhm,
show that if you're most engaged, if you are most involved, if you are most like top of your game and happy, then would you also be able to see that
mhm,
throughout, like see that that would make the clinician more effective, make the and maybe faster even, and make the
mhm.
patient have a better health outcome. And I think there's a lot to that. You very kindly redirected me. You were like, that's great, another time. And I think that's really wise that you're focusing on it's yet
Mhm,
yes, there are other implications. We know that interpreters are important pieces of this whole health puzzle
mhm,
for the limited English speaking population, deaf and hard of hearing population. Also, they, in order to make any of those other ripple effects happen, we have to understand what's going on with them first.
mhm,
And they matter by themselves. Like, we know that aside from how effective your interpreter is, rippling across the board for your patients and clinicians,
mhm.
it also, we just have a limited number of interpreters in general, and it's kind of a shrinking population. There's a ASL interpreter, like I don't know that you call it a
Shortage.
crisis.
Uh-huh.
Yeah, there is a shortage. Yeah. And so how one of the ways that we can help to make sure that there are enough interpreters is to make it a desirable profession. And that's, job number one is just enough interpreters to be able to support all the people who need
Right.
help.
Right. And
Yeah.
I can only imagine, that interpreters experience, what I'm gonna share is that because I think it's twofold. I really do want to shore up the, support systems for medical interpreters because of their, like I said, their presence there, and they do have influence and they should take some agency in portions of this, but that knowing that they also do have a portion of their role being passive, being, just that they're supposed to verbatim-ish, represent what's happening. And I can speak that I've been part of meetings where, I try to be, I took extra training in this. I try to be extra thoughtful in the words that I say and how I represent the information. And then every once in a while, I'll have a colleague that's saying things, not that I disagree with, but in a way that I might, not my style, in a way that I think it could be a little counterproductive or not as empathetic and compassionate as I think. And sometimes even me as a clinician colleague, even me being in the room sometimes and doing this, sometimes you can't stop it. And sometimes you're just like, and I can at least be quiet or try to be something. You're in the position where you have to repeat some things that were just said, and they might be filled with, like I said, at its best, I'm saying less kind ways of saying things, if not straight bias or something, so like that I can only imagine what it's like to be a part of a meeting that goes like that. And that's where, the clinician side of things, I'm also part of, plenty of education programs and just ways to try to support our clinicians and being their best compassionate selves, right? And hopefully not even putting your colleagues in that position, but that just to say that, there are going to be times where you're in that position, and that's I can only imagine how challenging that is.
So let me ask you a question. So this is a through line that I've heard coming up more and more, is like a questioning of the interpreter role. Because we have this pretty established model for what the interpreter is supposed to do inside of healthcare, and it's by and large be a conduit. That's the traditional model, is to be a conduit.
Correct.
After that, it's cultural brokership. So if you say something, the example that I use is like foster care. If you as the clinician say foster care to someone who's a Spanish speaker from Ecuador, that concept doesn't exist. So the interpreter will pop in and be like, hi, this is the interpreter speaking. Foster care is not a concept in Ecuador where the person is from. Can you provide a description and I'll interpret that, right? So cultural brokership. Right. Next is, or no, I'm sorry, it's clarifier next, then cultural brokership. So clarifier, like, excuse me, this is the interpreter speaking. I think the audio cut out. Can you say that again? Like clarify.
Yeah.
Then cultural broker. And then the last piece, smallest, is advocate. So when you absolutely need to, if someone is going to have something horrible happen, then advocate. And part of the shift that I'm seeing happen, especially in health systems that have their own internal interpreters, there's a questioning of like, hey, we know that these people that have these language skills and cultural skills could do more than just the conduit role. And so let's make sure that we're staying within that whole framework when we're in the appointment with the patient and provider. But what if we were to expand that role a little and also let them have them do like help navigating around the building, or what if they were to do in-language kind of support for people as they're walking around, things that aren't clinical or aren't medical, aren't health information, but helping to support as just an in-language resource. Where do I park? How do I find this part of the building? And I'm wondering, I love that. I think that's great. And I'm wondering if that's going to be more of a trend as we see, technology evolves. We know that there will be a time when some of the interpreting that's happening right now doesn't necessarily need a human. I absolutely believe we will always have human interpreters, but like scheduling conversations, things that are like not necessarily medical in nature, we could see automation for those. And so I see a potential future. I'm curious if you see this too, where interpreters use more of their cultural access skills. that they expand beyond just the conduit role. And we have to be really careful about that and make sure from a
Mhm.
compliance perspective, we understand that. But I'm picturing that that's kind of the way that we're walking. Do you see that
Yeah,
too?
I think in general, it's funny because so we are taught in, school that you should be doing patient, facing information at like a fourth, fifth grade level or
Mhm.
something like that. And then I think we as clinicians, we get into, other training realms and, like to impress each other, like to be smart. And, so then we up our game of how to explain things. And I think when it comes back to, patient and family situations again, I've seen here that, my incredibly smart colleagues, I think sometimes have trouble communicating with families on um just not dumbing it down, right? But just talking about it at a level to just to make sure that it's, able to be, taken in by everybody. And so I actually play that role sometimes. I'll be sitting in a family meeting and it is typically most appropriate for my role because it's honestly a little bit similar to the interpreter role of supporting my specialty colleague as the one that's taking the ologist of the disease you have, right? And they should be the ones telling you about how serious it is, about, how limited the treatment options are. And then I should support, what that means and moving forward, but they should be the ones doing the education. And every once in a while, I have to step in because I can see that a word they said, is kind of landing flat or something like that. And I could say, may I add, or did you mean, or, that, I might kind of jump in with a slightly different way, a less medical way of saying something. But of course, that took time to kind of get some of my comfort. I'm in person. This is a colleague, that's something that I can do in many situations. And so I do imagine we could, try to empower medical interpreters to do that, that they, if they notice that the language is getting, kind of elevated again, and there might be an opportunity to be like, excuse me, is there, a different way you could say that? Or, again, kind of trying to remember that in general, we're trying to keep things at the fourth, fifth grade level. I think my fear is that if we have the external person speaking up for that, and, that, are we offering a different service to different people based on, if they have a language need or not? And I don't want it to come across as we're assuming that people who don't speak English can't understand it at this level, and we're always dumbing it down. Or again, not dumbing it down is not the right, making sure it's at a clear
Yeah.
level.
Yeah.
Um, that opportunity should be there for everybody. So I don't know. I struggle with that, right?
Yeah. I mean, that is totally the question. Like, what does it mean to be an interpreter and what does it mean to provide access and equity? Like it could, because you don't want to strip someone of their agency and their ability to engage with the source material. Like that's
Mhm.
part of why the conduit role matters so much, is because you don't want to, even if someone is mean, even if a clinician is mean to the patient, you don't want to strip the patient of their ability to respond and be knowledgeable that someone was mean to them. Like that's, they're
Okay.
entitled to know that, like it depends on, I think like it depends also on the health system. Sometimes what you'll hear is health systems that have in-house interpreters, they want to protect the health system. And so they have a bit of a different model where they won't actually interpret something mean, because they're both acting on behalf of
Mhm.
the hospital, the same hospital.
You mean
But
like a side comment or something, like if something's kind of, yeah.
yeah, like if someone were to say something insensitive, I think that there are some models where the interpreter, instead of interpreting it straight to the patient, would go back to the provider and say, provider, that was insensitive. Please say
Mhm.
something, like please adjust. But typically, like in the most purest sense of the word, if the provider says something insensitive to the patient, the interpreter acting in the conduit role says the same insensitive thing. They don't take the edge off, um,
Right.
because the patient has a right to know and engage with that provider based on how they're treating them. So if they are insensitive, if they're being cold, the interpreter can't make it warmer because then they are acting as though the provider is warm. They have
Yeah,
they should have all their information. So that's one.
that's
Yeah.
tough.
Yeah. But then also, I think there's a question of like if we can provide enough transparency that this is how everyone is. I'm not obscuring anything from you,
Right, right.
but I'm also maybe filling in without making it so that you couldn't engage with the tougher thing. So like if you're using a lot of medical jargon, maybe the model is, hey, I interpret that medical jargon, but then I provide an option and I say,
Hmm.
hey, let me know if you can't understand and we can work through
Yeah,
like a definition.
yeah,
Um,
that's
I don't know. I don't
yeah,
know.
that's hard because even in my own work and in just English only, I have to decide when do I say, your loved one's about to pass away? When do I say your loved one's about to be gone or die? When do you use like which of those words?
Yeah. Yeah. Interesting stuff. I don't have
Yeah.
an answer, but I do think it's interesting. Um,
Well,
this
it's also what keeps our lives interesting and such, right? And even if you kind of are interpreting the same thing every day, it gives it some flavor.
yeah, it's true. Gives you decisions to make.
Mhm.
This is a little bit of a different path, but because it's top of mind. So at Globo, we have something called it's the PLACE survey, Patient Language and Cultural Experience survey.
Mhm.
And I recently took it. So we've had a handful of health systems participate. I took it to our Language Access Innovation Council last week. So they're all either language access or patient experience people.
Mhm.
We have a handful of interpreters that sometimes are there, but it's all language access and cultural experience kind of flavor people. And we were going through and getting feedback, and it got really tedious. We were going through like, hey, should we call out? I had on there, tell me what you think of this. I had on there in the patient journey, I had like admission,
Mhm.
check-in, like all the like standard things, but then I also called out pet therapy, art therapy, and other therapy
Mhm.
programs. That was a huge question, was like, is that an indication having language access for pet therapy, art therapy, and other like ad hoc like enrichment programs? Is that an indication of having a good language access program and patient language and cultural access and equity? Um, and so we got stuck there for a while. Before we move on, do you think that those should be
Well,
interpreted?
yeah, because then otherwise you might not have access to the things, right?
Exactly, I agree.
Yeah.
So, and also, like, even if you were to say, as you go through and you say, yes, we have language access specifically called out for these things, if you were to get to the art therapy piece and it's like, we don't offer art therapy, like, you're not going to be
Mm.
dinged for that. That's okay.
Okay.
Anyway, but as we were going,
I've never asked our art therapist if they feel empowered to utilize that. Um, or our pet therapy people. I don't know.
well, also like cafeteria. So if
Hmm.
there's patient and family who are going to the cafeteria and ordering, like
Sure.
that's something that you might not need as much level of language access there because you might be able to get by
Mhm.
with your English speaking skills. But like if you have an allergy or something, like it could be,
Yeah.
you could
I
need,
would say for us, you have to input a patient number.
mm,
So I don't have access without medical record, I don't think.
so maybe there's opportunity there. Um,
Right?
yeah, totally. So all of that to say, that was all just
Yeah.
preamble. As we were going through and getting feedback, it was getting like real tedious. So I was trying to take us back up to a higher level.
Hmm.
And what I ended up asking everyone was, is there a chips and guac of patient language experience? Like, you know how like people who love Mexican.
Satisfying or polarizing. What is chips and guac?
Oh, so the idea is people who love Mexican restaurants and people who are like reviewers of Mexican restaurants, they
Mhm.
say if you order chips and guac from a Mexican restaurant, it'll tell you basically everything you need to know about the rest of
Okay.
the
Okay. The
like
quality of the rest of it.
yeah,
Okay.
it's an indication of everything else. Is there like, and so this survey is so long, it asks so many questions. So my question was, is there one thing or like a handful of things that like if the health system is doing these things right, the patient experience across languages and cultures is going to pretty much be,
Okay.
what do you think?
I think it probably would be kind of what you were hinting at before. Is it that non-clinical staff, or at least, the other, support services staff feel empowered to zoop, boop, 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 just as fast as I do, because I don't think twice about it. I go, oh, did I get the MRN? Who can find me the MRN? Because you have to put it in before you can move forward. So, and that I don't always have at my fingertips. So, there's a pause, a little bit of a pause. But do I have the battery? Do I have, that's
Yeah.
about it. Is it a contact room or not? But I don't feel I don't feel bad at all about pulling it up for a 2-minute anything.
Yep.
But what does a person that's coming in and out to collect the tray, like a minor interaction, or environmental services, do they feel empowered to be able to do that or not? Or, as you were suggesting, security or some of these other things. Have we lowered the barrier and given, agency and access to those services?
Yeah. Yeah, that's good. I think so too. I think like the best indication probably is going to be the least the parts that are potentially least impactful. Like if those can happen in language, then you know that they should be doing a good job on the parts that are most impactful. Like the least the smallest piece, like that's an indication of what the biggest piece is going to do. So I agree with you.
And can some of those start to be more AI and more, immediate? Like maybe.
Yeah.
But yeah, I think that's it. Because I do also sometimes work at a different place. And I'd say that place is it's again not impossible, but a little bit harder and more tedious, and gotta find the number and a little bit, to the service is not as quick to respond like Globo is. So, every time I want to use it, you can't help but just be like, do I really, or should I just, go
Totally.
in, do my job, go out?
Yes.
Or call the family member instead who's willing. And, as long as it's not a key conversation, is that good enough? And counts as my family update for the day. So yeah.
Well, and this is not a plug for Globo at all, but I did love
But
that
we
you
enjoy
said
how fast they
we
come up.
do enjoy it. Yes.
Just
Okay.
the MRN. Ugh. Yeah.
I'll take that back. Put it on our roadmap. And then and also one thing that we talk about a lot at Globo too is that quality is not just the quality of the interaction isn't just the quality of the interpreting, it's also the quality of the technology. How easy is it to access? How fast is it to access?
Yeah.
Like having one of these kinds of stands or a similar stand, like it should be as easy to use as a person walking in, because otherwise why would you can't lessen the access just because you're using a different modality.
I agree.
So I love that you said that. Thank you.
Yeah.
My final question for you. So the audience that listens to this is mostly language access people, language access patient experience, some medical interpreters. That's really, and then Globo internal. If you had one message for that group of people, the people that are thinking about language access in the future, the people that are patient experience, people at hospitals and health systems, what should they know? What should they walk away from this conversation knowing about your study, or just your hope for the future? What do you want them to take away?
I think my hope for the future is to empower a little bit more of that agency out of the medical interpreters in these situations. Because I do think they play that important role. And that, to kind of, help us with that human ear as we're having kind of these challenging conversations, and that it's okay to, ask for clarifications there, ask for slowdown, ask, and things like that with these challenging conversations. And I think I want us to, or, what my new study is to see if clinician teams, engaging the interpreter a little bit early or asking them to stay on a little bit late, can improve any of that process, and that we might actually want and seek their feedback. Not just be like, well, my interpreting role is over, goodbye, sort of a thing.
Context.
Yeah, I'm really hopeful for that.
I think that would be industry changing, because we really do think about, especially when you think about like audio interpreting, video interpreting, it's like you're there for the interaction and then you're gone. Like it's thought about almost the same way as like a telephony cost, like just the
Mhm.
phone charge. And that's not necessarily outcome based. And like the rest of medicine is all moving toward this outcome based model and value based model. And so let's align our interpreting staff
Mhm.
to that too. Let's,
Yeah.
yeah, whatever we can do to make the patient experience better and also to make the team work
Mhm.
in more of a team fashion, like context
Yeah.
driven.
And did I get a chance to tell you about the new study?
Oh, not no. What a
Oh,
great thing. Go for it. Yeah. Tell us about what's
yeah,
happening next.
because I think we talked about the study that we did in finding out that the in-person interpreters had various reasons why they were more or less comfortable in situations, and we were preparing to be like, okay, well, that's the fix, right? That we found that people really enjoyed the pre and post meetings with the team, but that they didn't get them often. So we were like, all right, let's plan an intervention where we're going to encourage all of our clinical teams to do that pre and post with an in-person interpreter. And then we were like, wait a minute, we're using Globo a ton. We're not using in-person people anymore. And, so what's the right intervention to do there? Or what even are the feelings anymore of people who interpret in that situation? Because I don't even know what the virtual distance does to how interpreters feel. Maybe that, virtual distance actually, you know, improves their feelings of it. They can turn it on and off, they're not,
Yeah.
part as, deep into it anymore. Maybe they are plenty deep into it, and actually not being present with us means that they totally skip out on any support that we're even giving indirectly, even if we don't, meet with somebody afterwards. So it just left us with too many questions, even about what the interpreter experience is or what it's like to do the remote interpreting. So we were like, well, maybe, at first we were like, maybe we'll just ask that final question. Do you want to have pre-meetings or not? But like, no, back it up. We have to even find out how that experience changes their comfort level at all. So we're hopeful to roll out this survey to your Globo interpreters soon, asking for their perspective. You can reflect on your perspective if you've ever been an in-person interpreter, but more specifically, we're asking, how that's changed being a remote, a telephone or video interpreter, if that changes that experience at all, if you like that better for these hard conversations, if actually you miss the old way of in person, or maybe the answer is going to be just what we found with the other one. People have a spectrum of perspectives on it, and you can't know unless you ask. Maybe we're going to have the same conclusion.
I love it. Thank you for making sure that we got that in there. If you're a global interpreter listening to this, this is your heads up. So you're going to start to see this coming through and we'll provide more information. But we're really excited to be able to partner on that. Like I'm super interested to be able to get some of the insight from our interpreter pool. And also
Yeah.
as a human-centered designer, like the first thing that is part of that is you have to start from insight. You have to start from
Mhm.
talking to people and understanding what people think. And so this is very human-centered design of you,
Yeah.
which I really, really appreciate.
Thank you. Yeah, I just I have really enjoyed my experience with Globo interpreters, and I do want to change the culture, because I think I did one day. I was like, let me stay on with this person and be like, how are you? And I think people aren't used to it anymore. They're like, okay, good. Are you done with me? Bye.
Exactly. Yeah.
And so I think it's going to take a cultural change on both sides of our thing, if that's even the right intervention here. And I'm open to people telling me, we got this, we're good, you go about your day, you're busy. But I think we want more connection than that. And so I'm
Totally.
curious.
Well, and I also think for the interpreter, knowing that this is allowed, because for so many, depending on the
Mhm.
client, it's like, we don't want to waste the time here, keep it moving.
Mhm.
So then there's also that piece of like, if it's not a total industry shift, then how do we make sure that interpreters are able to be nimble and be like, okay,
Hmm.
this customer,
Right.
this use case, they don't want me to hang on. This use case, they do want me to hang on. So there might also be some interesting product and technology things that
Right.
come out of this too, which is great.
Right. And to advocate that, on the productivity side, on the employer side, that people aren't penalized
Yep.
for, trying to participate in some extra time, things like this, that it's not somehow negatively impacting the job of the interpreter.
Yep,
Right.
absolutely.
That's really important.
Yep. Which for us it would not be, just as a heads up. So if you're an interpreter listening, don't worry about that. Um, all right, Katie, is there anything else that we did not talk about that we should talk about today?
Think so. Thank you. This was great.
This was so fun. Thank you for hopping on. Thank you for making the time. I'm really excited to see the results of the next phase, the survey with Globo's interpreters.
I'll be back, right?
And yeah, there we go. All right. Well, thanks, Katie. Have a great afternoon. See you soon.
Thank you.
Bye.